I'm a psychiatrist at Ahmadu Bello University Zaria in Nigeria and a member of the advisory committee for Africa CDC on NCDs, injuries, and mental health. We have a presenter that will be speaking in French. So I suggest that if you don't have the headphone for interpretation, you can get one before we start. The headphones are available for interpretation. Non-communicable diseases have constituted a growing public threat in Africa. And in this session, we will review the epidemiology of non-communicable diseases, mental health and injuries in Africa. We'll discuss the challenges in achieving universal health coverage for mental health, non-communicable diseases and injuries in the African context. And we'll also explore processes for integrating NCDs, mental health and injuries, into all levels of healthcare services, especially community-level healthcare, and identify opportunities for increased direct and indirect funding for NCDs, mental health and injury programs among African member states. Within this framework, the presenters will explore road traffic incidents, cancer, psycho-ecology, geriatric care, other mental health issues, relevant topics for discussions. One of the objectives of this session is to stimulate discussions from participants, especially after presentations by speakers on different homegrown and innovative strategies required to tackle this emerging burden of NCDs, injuries, and mental health in Africa. So after presentations, we'll have a set of panelists who actually made the presentations for you to ask your questions. So at this point, I'm inviting Dr. Mary, who is coming up as a co-moderator and co-lead of this track to introduce the speakers. Dr. Mary, please.
Good morning. Good morning. I know yesterday didn't turn out like we wished, but our African team did well, isn't it? Let's clap for Morocco. They've done well. I want to welcome you to this session on non-communicable diseases, mental health, and injuries. We had a pre-session yesterday, actually two, and this morning we had one that was looking at media and non-communicable diseases. And therefore, without further ado, I want to welcome our panelists. But before I do that, I was reminded to introduce myself. My name is Mary Amuyunzu Nyamongo. I'm a social scientist from Kenya with the African Institute for Health and Development. I'm also an advisor to Africa CDC on NCDs. We have a very able team of panelists. Some will be joining us virtually, but we have several in the room, and I'll call them to join us forward, after which we shall go into the presentations. We have Dr. Prebo Barango, who is a medical officer, communicable and non-communicable diseases with WHO, the African region. Let's clap for Prebo as he comes. We have Professor Jibril Abdul Malik, who is a psychiatrist, lecturer, University of Ibadan in Nigeria, and founder of ASIDO Foundation. Let's clap for him as he comes. We also have in plenary here Dr. Hassan Ghanen, Professor of Community Medicine and Public Health, Faculty of Medicine, Suzy University in Tunisia, and advisor to Africa's CDC on NCDs. Let's clap for him. In-house, we also have Professor Janine Chodo, who is from the Center for Impact Innovation and Capacity Building for Health, Information Systems, and Nutrition here in Rwanda. Let's clap for her as she comes. Virtually, we are joined by Dr. Oswald Gauko-Daja. He's an orthopedic traumatologist and surgeon based in Benin. Let's clap for him. He's actually online. We shall then be joined by Professor Anna Mokumbi, who has a pre-recorded presentation. She belongs to the NCDI Poverty Network. She is also an associate professor, University of Eduardo Mondlane, and an affiliate professor of University of Washington. Let's clap for her too. So I don't know whether we are talking about NCDs, the hall is a bit empty, or the march took some of our sleep, so we shall launch into the presentations this morning. We'll start with our brother, Dr. Prebo Barango. Welcome.
Good morning, distinguished colleagues, ladies and gentlemen. Can we have the slides? Thank you. So I'm going to be looking at an overview of non-communicable diseases in the WHO African region. The outline of my presentation will be that I'll first talk about what NCDs are in Afro, look at the burden of NCDs, look at the impact of COVID, our response, and then monitoring and evaluation approach to NCDs. Now, let me start with that. In 2011, the ministers of health from the African region actually defined what we meant by NCDs, looking at the NCDs of public health importance in the region, and went beyond the 4 classical diabetes, cardiovascular disease, cancers, and chronic respiratory disease, to insist that NCDs in the African region would include hemoglobinopathies, mental disorders, oral health, ear and eye health, as well as violence and injuries. And they also concluded that NCDs are not just a health issue, they are also a developmental issue. This was 2011, before the, in April, before the first UN high-level meeting on NCDs that actually agreed on the 4 NCDs and the 4 risk factors for NCDs. That's the 5x5. In 2018, at the third UN high-level meeting, the 4 NCDs were expanded to include mental health, and a 5th risk factor of environmental pollution was included to the other 4 risk factors of tobacco use, harmful use of alcohol, physical inactivity, as well as unhealthy diet. So those were the key NCDs and the risk factors. In the region, we actually are having a huge burden of this, and they are beginning to constitute a higher proportion of mortality, morbidity in the region. So in the region, for all NCDs, cardiovascular disease is the most prominent and contributes more to mortality, followed by cancers, and then chronic respiratory diseases, as well as diabetes. Mental health also contributes 16% to mortality in the region. And like I mentioned earlier on, the other NCDs, including trauma, also contribute to mortality in our region. Key for NCD mortality in the region is not just about contributing significantly to mortality, but also contributing significantly to premature mortality. WHO defines premature mortality as mortality that happens between 30 and 70 years. And as we are aware, those are the key, it's not that mortality at other ages are not important, but these are the key people that will contribute to the economy and drive the economy. And so in the African region, we actually contribute much more significantly to premature mortality burden. So having said that, it's not just about premature mortality burden, but it's a developmental issue. We know that the key drivers of our economy will be those within that age range, and these people are affected, impacted. It affects economies, it affects society, and we need to do something about this. Now, for most countries in the African region, what I'm trying to show here is that it's not just NCDs that is the problem. Due to epidemiological transition that most countries are witnessing, we are seeing that countries are having what we call the double burden of diseases. There is still the maternal, prenatal, perinatal, and nutritional causes of mortality, as well as infections. We still have those. And so what I'm trying to show here is that countries in the African region are grappling with, double burden of disease. And the extent to which this contributes to total mortality varies from, for example, at the extreme left is Central African Republic that has a preponderance of mortality from communicable maternal and nutritional conditions, to Mauritius on the extreme end of it that has preponderance of non-communicable diseases and injuries contributing to their mortality. So this affects resource mobilization and resource allocation as well as human resource. So those are things that we need to consider when we are looking at mortalities from the ability to respond adequately to NCD in our region. Now, in terms of what's the thing driving these mortalities are the risk factors. The risk factors are on the increase. Here I'm trying to show that the prevalence of raised blood pressure across all the countries in our region. And we can see that the green line across all is the global average. Most countries in our region are actually way above the global average for hypertension, the prevalence. But that is not that's actually not the breaking news. The breaking news is that over 2/3 of people with hypertension are either not aware or undiagnosed or on optimal treatment. And we know that hypertension is a key risk factor for cardiovascular diseases, and it complicates other NCDs. So that's really a major issue. In terms of risk factor for behavioral risk factors, alcohol, in terms of alcohol consumption, varies across all countries in the Euro region, and it's really not changed much between the past 2 decades. For the burden, cancers are really a major issue. We know that, for example, childhood cancer, survival rate for childhood cancer in our region is between 20 to, the best countries have about 20 to 30% childhood cancer survival rates, while in developed countries it's over 80%. Cervical cancer, we have the highest burden. 19 of the 20 top countries with cervical cancer, but the highest burden of cervical cancer are actually, unfortunately, in our region. So these cancers are not really public health issues in developed countries because there are, we know the pathophysiology, we know what causes it, and there are cost-effective interventions to curb this across prevention, early diagnosis, screening, and treatment. Diabetes is also not, it is also something that it's really creeping up in our region. Diabetes, we have, we are accounting for the highest rise in diabetes. the estimated 24 million people with diabetes in the African region, only about half of them are diagnosed. The other half are not diagnosed. We don't know what is happening to them. So the question we will I'll pose is, how many people know their status in terms of hypertension, in terms of diabetes? The other NCDs is the injuries and trauma, and we know that the most common cause of trauma and injuries in the region is from road traffic accidents. We have the highest incidence of road traffic accidents, although in terms of motorization, we are the region with the lowest per population in terms of motorization. So there are policies and things that need to be implemented to really correct that. So I've mentioned all this, but the thing we know in the past two years is the impact of COVID-19 on our population as well as on NCDs. And COVID-19 has actually exposed the gross underinvestments in NCDs over the years. There's a deadly interplay between COVID-19 and NCDs. We know that people with NCDs succumbed most to COVID-19. If they had COVID, they were most likely to have more serious complications or to die from it. We know that during COVID-19, as part of the public health measures for COVID-19, health facilities were closed. People with NCDs were not diagnosed or they didn't have access to their treatments. And you know, people with diabetes or hypertension, it doesn't matter, you need to really continue taking your medicine. And of course, they were also not protected from the risk factors of NCDs during COVID-19. There was restriction in movement, and of course, there was also, because of the pressure and the mental health effect of COVID-19, there was more things about, you know, partner violence and the use of substances. So now, for the response, what have we done so far? Let me start by saying that I want to appreciate that over the past 2 decades, the African region, we have really made a lot of progress in terms of providing services and increasing service coverage over the past 2 decades. And you will see from here that the service coverage index generally has increased between 2000 and 2019, but we have done a lot better in terms of service coverage for infectious diseases as well as maternal and child health conditions. But with NCDs, the service coverage has actually been a bit stagnant. So it's something that needs to be addressed. And to address this, it's not a competition between prevention and treatment. We know that between 50 and 60% of NCDs can be prevented. So implementing prevention interventions really is cost effective, and as well as implementing and providing capacities and infrastructure for treatment. Those are really important. So it's not either to focus on prevention or to focus on treatment, but to focus on both and to look at the most cost-effective interventions that we are able to implement. And WHO has come up with a few suggestions on how to do this, which ranges from looking at providing access to treatment, and ensuring that people with NCDs are involved in designing and implementing interventions that concerns them. We've over the past yesterday's sessions, there were a lot of sessions on digital health. We also need to explore the use of digital health to expand coverage to prevention, early diagnosis, treatment, as well as data for NCDs. And so WHO, we have what we call the signature solutions to which are cost-effective interventions that governments and member states can implement. And these signature solutions range from signature solutions for treatment of NCDs, including global health initiatives. We have a global health initiative for cervical cancer. We have one for childhood cancer. We have one for cardiovascular diseases, as well as signature solutions for prevention, which includes signature solutions like the Empower for tobacco, and the other interventions for prevention of NCDs. So I'm going to round up now. In terms of approach to evaluation, monitoring and evaluation of NCDs, it's within the framework of the Global Monitoring Framework, which has the 9 voluntary targets. The 9 voluntary targets include things for premature mortality prevention, health systems response, as well as risk factor prevention. And initially, the target was set for 2025, but in order to align with the SDG targets, the target has been set now for 2030, but it's still the same. Most of the targets remain unchanged. My passing shot will be that member states, we need to really integrate NCDs into PHCs as part of the UHC agenda. And each country should look at what NCDs are the most important and contribute more significant to premature mortality in their context, and implement cost-effective interventions to ensure population coverage, which would including NCDs as part of UHC benefit package, which will include things like ensuring that at the PHCs, things like hypertension and diabetes can be easily diagnosed and treated, as well as strengthening referral networks across these services. So success, for what does success mean for member states to achieve the NCD target in the SDG? Well, there's going to be a UN high-level meeting in 2025, to look at the commitments that has been made and see progress on it. And success will be that partners are investing in NCDs. NCDs contribute significantly to mortality, but in terms of development assistance, it's actually very, very minimal. And also success will be that people living with NCDs are empowered to be able to self-monitor and really self-care, and empowered to be able to raise their voice and be counted in terms of what they need and how they need to get those services. The time for action for NCDs is now. Thank you very much.
Thank you so much, Dr. Prebo, for identifying some of the challenges we have. I was actually attracted to your observation that of the interplay between undiagnosed, untreated, and unprotected. I think we need to think about this as we discuss issues to do with NCDs. I would like to recognize the presence of the Acting Director General, Dr. Hamed Ogwel, and the Minister of State for Health for Rwanda. Welcome. I know Dr. Ogwel is committed to NCDs, and it's a pleasure to have you in the audience. I would now like to, thank you. I would like to welcome Professor Jibril Abdul Malik from the University of Ibadan to talk to us about achieving universal health coverage for mental health in Africa. Welcome.
Good morning, distinguished ladies and gentlemen. It's a pleasure to be with you, and I'm going to essentially be an advocate for mental health within NCDs. And what I'm tasked to talk about is achieving universal health coverage for mental health in Africa, the case for integrated community care. Next slide. Am I supposed to? Okay. Right, so I will talk to us about this story by talking about the burden of mental health within NCDs, as well as emphasize the challenges that we face in addressing these challenges across Africa. We'll then talk about universal health coverage and what is the way forward. That way forward is to ensure that there is integration and community-based psychosocial interventions for mental health services. And so when we look at the global burden of disease study, which I'm sure we are all familiar with, we look at NCDs and you isolate NCDs alone, you find that neuropsychiatric conditions alone account for 28% of the NCD burden, measuring using DALYs. And if you then expand that pie chart, you see that all of endocrine disorders is 4%. 4%, so all the diabetes, the thyroid dysfunction, all the endocrine disorders, 4%. You look at all the cancers combined, breast cancer, prostate cancer, skin cancer, cervical cancer, 11%. Whereas neuropsychiatric disorders alone, 28%. And if you expand that neuropsychiatric disorders, you find that unipolar depression alone accounts for 10% of the global burden within the NCDs. Now let's go further and look at years lived with disability as a measure of the morbidity of those suffering from mental disorders, and you then find that it's about 18.9% looking at years lived with disability. And if you add substance use disorders, you will have 22.8%. Because of the chronicity of most mental disorders. I'm using these slides to sort of lay the ground for us to appreciate the burden of the problem. You find that 70% of the burden of mental disorders globally is in low and middle income countries in blue, while 30% of the burden is in high income countries. But look at the next series where you look at the resources, global resources in terms of personnel, in terms of financial resources, and you find that low-income countries have 10% of global resources to address 70% of the global burden. Whereas high-income countries have 90% of the resources to address 30% of the global burden. So you begin to appreciate the enormity of the challenges with respect to mental disorders within the context of low-income countries and especially on the African continent. Now, this is from the WHO World Mental Health Atlas. It shows the distribution of psychiatrists across the globe. Now, look at Africa, essentially red, with the exception of 2 countries. What that means is that in those countries, we have less than 1 psychiatrist per 100,000 population. And that is actually a very kind denominator, because in reality, it's about 1 psychiatrist to 1 million population. But we'll take that denominator and we'll run with it. What are the challenges across the continent facing addressing mental health problems? One of the challenges is the absence or poor implementation of legislation, policy, plans across the continent. Many countries in the continent do not have these governance documents. And where they do have them, implementation has been non-existent. Ignorance is also a huge problem. Ignorance, superstitious beliefs, and so several pathways to care across the continent clearly demonstrate that most individuals with mental disorders will go to traditional healers, go to faith-based healers before they think of going to the hospital. And this is largely because of ignorance and the belief in the supernatural causation of mental illness. And of course, deriving from that, you have a lot of human rights abuses, chaining, beating, deprivation of food and drink for individuals where you say you want to do exorcism. In the Christian faith, it's deliverance. For the Muslims, it's ruqyah. And in some of these instances, it involves beating, physical beating of the individuals suffering from mental illness. Of course, stigma and discrimination is the big elephant in the room, where people say, oh, don't marry from that family, somebody there has a mental illness, and so on. There's, of course, the vicious circle with poverty. And we know that many African countries do not have effective health insurance. And some of these countries where there is health insurance, mental health is very poorly, if at all, covered. And so you have the problem of out-of-pocket payment for services, and that guarantees financial barrier to accessing mental health services. Unavailability of medications. At the opening ceremony, this was mentioned, a situation where we don't have capacity to develop and produce our own medications and all of that. So we have new medications that are too costly. Drugs like methylphenidate for ADHD in children is not routinely available across the continent. Where it's available, it's prohibitively expensive. We also have very few mental health professionals. If you recall the map of the world from the atlas I showed, across Africa, very few psychiatrists, and it's not just psychiatrists, very few psychiatrists, very few clinical psychologists, very few social workers working in mental health, very few psychiatric nurses. So it's across the spectrum of mental health professionals to offer services. And we also have difference between urban and rural. Everybody wants to be in the big cities so that their children can go to good schools. Nobody wants to be in the rural areas. And ultimately, if you put all of these challenges together, it culminates in a huge treatment gap, which you will see in this slide. The WHO did a World Mental Health Survey across 14 countries in all the regions of the world about 15 years ago. And what they found from that study was that the methodology was to look at the preceding, it was a community-based survey, to look at the preceding 12 months, how many people with mental disorders did not have access to care. And across the developing countries, it was a range between 35 to 50%. So what that meant was that even in high-income countries, not everybody with a mental illness was able to access the care they needed. But of course, if you look at the pink lines, that's for developing countries, the treatment gap was much higher, between 76 to 85%. And of course, that's where most of Africa fall. For Nigeria, where I come from, the treatment gap was 80%. Let's contextualize that. What that means is that every 10 individuals with a mental disorder, only 2 were able to access care in the preceding year. Let me move forward quickly. And of course, stigma, human rights abuses. This was a Human Rights Watch report from Nigeria talking about the woeful condition of persons with mental illness. A similar report was also published from Ghana a few years back. And this is some of the conditions you find with persons with mental illness in several places where they are chained and they live in very deplorable condition. Now, the hospital on the top of the slide is the University College Hospital, Ibadan, where I work. 1,000-bedded hospital, very big, and then you juxtapose that with traditional and spiritual healers where people are chained. What is the way forward? How do we achieve universal health coverage for mental health services? Should we build more shiny 1,000-bedded hospitals, or should we integrate into primary care and into community? Of course, the promise of universal health coverage is to leave no one behind. I'm going to move very quickly now because of time. And the Comprehensive Mental Health Action Plan of the WHO has 4 objectives. I'm going to focus on the third one, which says the provision of comprehensive, integrated mental health and social care services in community-based settings. And this is what we really need to focus on. This is the answer to our problems. We don't need to build more specialist hospitals. We need to go away from that mindset. What we need to do is go into the community, equip primary care, equip social workers, equip teachers, religious leaders, train them to be able to interact with the community and deliver quality services, and only refer the difficult cases to specialists in the hospitals. And that is captured in this diagram. So I mentioned this, that we need to train. We also need innovative solutions, like the Friendship Bench innovated by Dr. Dixon Chibanda from Zimbabwe, where he got elderly women to talk to women with depression in villages, not health workers. And the results were astonishing. Very effective. Grandmothers and elderly women in the village, very effective in addressing the problems of women with depression, especially in the perinatal period. mental health advocacy is also a key intervention that we need to focus on. The truth is that most people lack knowledge, and where you do not have the right information, superstitions and other things, rumors will fill the gap. So we need to pay attention to advocacy and awareness. And we also need to pay attention to the 4 aspects of public health in addressing these issues: mental health promotion, mental health prevention, early identification and treatment, and rehabilitation. And the first 3 you can do very well effectively within the community, in primary care, in schools. And so in conclusion, I say that we have a lot of daunting challenges. However, it's not all gloom and doom. The ball is in our court to put on our thinking caps. Let's stop lamenting that we don't have resources. Let us look at the resources we have: primary care workers, school teachers, religious teachers, community leaders. Equip them, educate them, change their mindset, let them be champions of promoting mental health awareness, and we will make significant progress towards achieving universal health coverage for mental health services. Thank you very much.
Thank you. If there is a condition that we all really need to focus on the continent, is mental health. He talks about comprehensive, integrated, community-based. Let's reflect on this. I would like to invite Dr. Ogwell, the Acting Director General, to come and make a brief presentation to speak to us very briefly, and then we shall continue. Welcome, Dr.
Thank you. Thank you very much, Mary, and good morning, colleagues who are here, those who are joining us online, your timeline, good morning, good afternoon, good evening. I'll not make a long presentation, but for those who may not know me very well, my public health life started in NCDs. So this is an area that is very close to my heart, and I wanted to share just 1 or 2 things as this fantastic panel here continues to beat you with a lot of information. The previous speaker, I pick one thing from that presentation, and that is, you call it the friendship bench. You know, I think we need a friendship bench during this conference as well. I don't know how we'll be able to make one so that it can be able to address some very significant mental health issues for those who are not sleeping, to make sure the conference is actually running very well. But imagine you had a friendship bench in each and every institution and in each and every village. Imagine just how much reduction in stress that would be able to afford us. Very simple and very effective. Which brings me to the 3 messages that I really wanted to share with you here today. One is, when we say NCDs, in fact, the title of the Africa CDC's newest strategy is so long that you have to swallow saliva twice before you finish. It is a strategy on non-communicable diseases, mental health, wellness, injuries, and something. Sometimes you don't remember the whole of it. You know why we do that? It's because we take everything into one big basket. In fact, we take everything into one small basket. We've put NCDs, we've put injuries, we've put mental health, but if you go and unpack it, NCDs alone are many different conditions and risk factors, which if you picked one by one, are probably more of a burden than the things that we talk about a lot: COVID, Ebola, etc. So let's look at NCDs and unpack it to be the really large area that it actually is. Second that I wanted to share is, let's move into applying those solutions that actually work. Friendship bench. It will be really nice, and if we could be able to find opportunity of expanding that idea of a friendship bench and see how it actually works elsewhere on the continent, not just in Zambia. Because there are solutions that have been shown to work, why aren't we making it normal for us to work on the continent? So any local solution which is low cost in nature and involves the community, so it means those of us who are well trained don't have to be there, let's apply those. Let's not just talk about them, but let's apply them in every context here on the continent. And the friendship bench, I hope, is going to be one of those that are going to be applied a lot more widely going forward. The last message that I have is let's also show progress that we are making. Many times we focus on the big strategies that have been developed at the global level, continental level, regional level, and we don't present the success stories that come from our communities. And the larger picture then tells you that things are really bad, which is true. But then within the larger picture, there are very good success stories that we also need to be sharing so that we show progress, that we came from here and we have moved until there. It gives us the momentum of confidence that we need to be able to handle this very large area that everything has been squeezed into, and yet it affects so many of our citizens. So those success stories, those successful interventions, particularly the ones that are low cost and relevant to our context in Africa, let's publish them, let's talk about them, let's adapt them and ensure that they are spread throughout the continent. As Africa CDC, we are committing to two things. One is we will work with each and every partner who is willing to provide support to our member states here on the continent. And second, we are going to put our resources as well in making sure that these innovative ideas are not only being implemented, but they're also being shared across the continent as something that is ours, something that actually works. NCDs, injuries, mental health is not one basket. It is very many baskets that have been squeezed into one basket. Let's unpack all these baskets so that we can be able to see the challenges of diabetes, of cancer, of all the risk factors, of mental health. Let's unpack those so that we begin talking about the long list of diseases and risk factors rather than making it sound like NCDs is just one item. And for our member states, when you're making your budgets, please don't make NCDs one budget line. Don't make NCDs one budget line. There are so many different aspects of NCDs, and we need to capture those in their detail in which they are required. For the panel, please let's continue to share and also challenge the audience with some solutions, like the friendship bench, that they can be able to go and apply when they leave here. I know I'm going to have a friendship bench in my office very soon, and I will see how that one is going to work. So you should do the same in your institution, and then let's share the results when we next meet, hopefully before the end of next year. Thank you.
Thank you, Dr. Ogwell, for your sustained commitment to NCDs, and we can see the energy within Africa CDC. We want to continue with our presentation. For those who have come in now, we interrupted a bit to listen to the Acting Director General. We will now move to Oswald Goukadaja, who is based in Benin. He will talk to us about road accidents in Benin, current situation, and perspectives. He will be presenting this virtually, and it will be in French. So if you do not have a headpiece, please, can you pick one? Thank you. Please, thank you, and welcome.
Thank you. Thank you. Bonjour à tous. Bonjour, chers congressistes. J'ai l'honneur de vous présenter ce matin les accidents de la voie publique comme problème de santé publique au Bénin, état des lieux et perspectives. Ce travail a été préparé avec la collaboration de collègues chirurgiens traumatologues et médecins en santé publique de l'Institut régional de santé publique du Bénin. L'OMS s'est intéressée aux accidents de la voie publique depuis 2004 en raison des nombreux dégâts humains que ce phénomène cause au niveau des couches les plus défavorisées. L'OMS a pu retrouver une importante association entre le niveau de revenus des pays et le décès de nombre de patients. Ainsi, actuellement, nous sommes au deuxième plan décennal et il est important de faire un état des lieux. Quelle est la situation actuelle en Afrique? Les pays sous-développés payent un lourd tribut des accidents de la voie publique avec plus de 26 décès pour 100 000 habitants. Et ce sont les couches les plus vulnérables qui sont atteintes, notamment les piétons et les cyclistes. Le rapport de l'OMS de 2018 a permis de comprendre qu'il y a une absence de législation concernant les importants facteurs de risque qui sont énumérés, à savoir la conduite en état d'ébriété, la vitesse, le port de ceinture de sécurité, le port de casque, mais aussi des facteurs environnementaux tels que la qualité des véhicules et la qualité des routes. Intéressons-nous à présent à la situation au Bénin. Au Bénin, il existe très peu de données statistiques au sujet des accidents de la voie publique. Le Centre national de sécurité routière a présenté un rapport en 2018 qui nous a permis de retrouver 5700 accidents de la voie publique avec plus de 700 décès, atteignant les couches les plus vulnérables. Les statistiques du ministère de la Santé, quant à elles, ne sont pas en conformité avec celles du Centre national de sécurité routière. On peut quand même noter que les accidents de la voie publique viennent au 4e rang pour le recours aux soins et que la mortalité hospitalière est de 12% pour les accidents de la voie publique. Quelles sont les lésions les plus fréquentes en termes d'accidents de la voie publique? Voici ce travail prospectif qui a été fait sur 2 ans et qui a permis de constater que les sujets étaient d'âge moyen de 34 ans et que les lésions les plus fréquentes étaient au niveau des membres inférieurs, en particulier au niveau du fémur. Sur cette diapositive, on peut voir à gauche une fracture ouverte du fémur, au milieu de l'écran une plaie du thorax avec hémopneumothorax et à droite un écrasement de jambe. Sur celle-ci, on peut voir en haut à gauche des fractures ouvertes de la main, un écrasement du pied au milieu et à droite des lésions comme un traumatisme vertébro-médulaire et ici une luxation du rachis, mais aussi des lésions du crâne comme en bas à gauche sur cette diapositive, un hématome sous-dural chronique. Une analyse des facteurs environnementaux a été faite sur la base de données collectées par la police entre 2008 et 2015 et a permis de mettre en valeur des facteurs importants de décès tels que l'accident survenu en milieu rural, les accidents survenus les jours de marché ou les jours de festival. Enfin, ce travail prospectif sur 185 blessés de la voie publique hospitalisés dans les hôpitaux de Cotonou, nous avons utilisé la fiche d'enquête modulaire sur les conditions de vie des ménages qui nous a permis de constater que les patients étaient le plus souvent de niveau socio-économique bas, ce qui nous permet de retenir que les accidents de la voie publique suivent un gradient social de santé. À présent, intéressons-nous à comment gérer la sécurité routière au Bénin. une seule institution, le Centre national de sécurité routière, qui existe depuis 1987, a le lead, avec comme partie prenante la police républicaine, les sapeurs-pompiers, mais aussi certaines ONG et associations. Pour la collecte de données, on utilise au Bénin le bulletin d'analyse des accidents de la voie publique, sur lequel les informations sont cochées par les éléments de la police républicaine et transmises au Centre national de sécurité routière. Beaucoup de faiblesses à ce niveau, c'est que les fiches sont mal remplies et il y a quelques problèmes de géolocalisation, mais aussi et surtout, il n'y a pas de corrélation entre les données du Centre national de sécurité routière et les données du ministère de la Santé. Au plan stratégique et au plan légal, la Convention de Vienne sur la sécurité routière a été ratifiée par le Bénin très récemment. Le plan décennal n'a pas encore été validé et le plan national de sécurité routière ne l'est toujours pas non plus. Et au Bénin, actuellement, la loi sur le code de la route est actuellement en étude à l'Assemblée nationale. S'agissant de la sécurité des usagers, il y a une absence au niveau de la législation concernant les différents facteurs de risque. Cependant, depuis quelques années, depuis bientôt 5 ans, il y a une vaste répression, une importante répression sur les voies publiques par les éléments de la police républicaine, ce qui permet de modifier considérablement les comportements des usagers. Ici, sur cette diapositive, vous voyez des photos des conducteurs de taxi-moto, communément appelés émigrants. Il s'agit d'un phénomène qui est en vigueur dans les grandes villes de Cotonou. Ce sont des conducteurs de taxi-moto qui ne disposent pas de permis de conduire et qui sont des vecteurs des accidents de la voie publique. S'agissant de la mobilité au niveau des routes, il n'y avait véritablement pas de procédure de construction, d'inspection et d'audit des routes. Donc, les signalisations n'étaient pas conformes, les routes étaient mal éclairées. Mais depuis 2018, il y a un vaste développement, un important développement du réseau routier avec asphaltage, ce qui a permis de changer le visage de presque toutes les grandes villes du Bénin. Au sujet des véhicules, ils sont souvent très vétustes, d'âge moyen 15 ans, suivant un rapport de l'Agence nationale du transport terrestre en 2010 et 2017. Et il y a très peu de mesures qui incitent à acheter des véhicules neufs, sauf seulement cette année, la loi des finances qui a exonéré des taxes par rapport à l'achat des véhicules. Des centres de contrôle technique existent, mais malheureusement ne prennent pas en compte les motocyclistes. S'agissant des soins aux blessés de la voie publique, c'est surtout les sapeurs-pompiers qui assurent le transport des blessés vers les établissements de santé parce que le service d'aide médicale pour les cas urgents, notamment le SAMU, est payant. Au plan de la couverture géographique des établissements de santé, nous disposons au Bénin de plusieurs établissements de santé d'ordre départemental, zonal, des centres de santé d'arrondissement, mais aussi un centre de référence qui accueille les grands blessés. Il existe aussi 2 facultés de médecine et des écoles supérieures de formation des agents de santé qui interviennent dans la gestion des blessés de la voie publique, notamment les techniciens de radio, les chirurgiens traumatologues, les médecins urgentistes, etc. Nous avons aussi un fonds de garantie automobile qui sert à financer la prise en charge des blessés de la voie publique, mais malheureusement, il n'est pas activé en urgence. Malheureusement aussi, les motocyclistes ne sont pas couverts par les assurances pour l'instant au Bénin. Quelles sont à présent les perspectives? Il serait intéressant au Bénin de développer le concept de la santé dans toutes les politiques, qui est un concept qui prend comme lead le ministère de la Santé, en ce sens que toutes les politiques publiques, les décisions au plan politique doivent tenir compte des conséquences éventuelles que cela pourrait avoir sur l'état de santé des populations et donc mettre en place les mesures pour conserver la santé des populations. À ce titre, donc, le ministère de la Santé pourrait rédiger et valider le programme national de lutte contre les accidents de la voie publique, travailler avec le ministère des Infrastructures de transport pour mettre en place des procédures d'audit des voies, mettre en place une surveillance épidémiologique sur l'ensemble du territoire, de sorte à travailler avec le Centre national de sécurité routière et utiliser des données fiables. Il serait bien que le ministère de la Santé aussi travaille avec le ministère des Finances et le ministère des Transports pour mettre en place de nouvelles mesures incitatives à l'achat de véhicules neufs. Il faut obligatoirement travailler pour l'incidence maladie pour tous, de façon à permettre une prise en charge immédiate des blessés. Le ministère de la Santé pourra, dans ce contexte également, travailler au recrutement des spécialistes en matière de gestion des blessés, parce qu'au Bénin, actuellement, nous sommes 6 chirurgiens, traumatologues, orthopédistes dans la fonction publique, avec 4 dans le centre national de référence, un autre dans un centre périphérique et un dernier dans le nord du pays. Donc, c'est très insuffisant. Il faudra travailler à améliorer le plateau technique de sorte à lutter efficacement contre l'exode des médecins vers les pays du Nord. En conclusion, les accidents de la voie publique sont un véritable problème de santé publique au Bénin parce qu'ils atteignent les couches les plus vulnérables, les motocyclistes, et il s'agit de sujets de niveau socio-économique bas. Les lésions sont plus fréquentes au niveau des membres inférieurs et nous devons travailler surtout sur la législation, améliorer le plateau technique et développer le concept santé dans toutes les politiques. C'est sur cette image de la statue de l'Amazone, sur la place de l'Amazone à Cotonou, que je vous remercie pour votre aimable attention.
Thank you very much for the presentation. I think in many of our countries, many cities, accidents brought by motorbikes are a key issue. In Kenya, we have wards dedicated to motorbike accidents. We really do need to act on this. I would like to welcome Janine Shondo to come and talk to us about the good things happening here in Rwanda. Welcome.
Thank you, Mari. Thank you, everyone, for inviting me here. As we said, as we heard as well, NCDs are growing up. NCDs are housed in low-income countries, as we heard from our colleague from WHO. And then, unfortunately, NCDs are contributing to almost 44% to 48% of deaths. So Rwanda, as many other countries in Africa, is also bearing those burden. In Rwanda, for example, 44% of deaths are accounted for NCDs. And also, actually, the probability of dying between 30 and 70 years is 18% due to NCDs. So we need to, thank you. We need to work hard. We need to work as if it's a multi-sector issue. It's no longer a problem of health, Minister of Health only. Causes of NCD, we just heard, go from long sitting hours to smoking to anything that we do. So causes of NCD are created by these multiple approaches or multiple behaviors. And also consequences are also affecting all the sectors. You can name it: economy, education, and others. So I'll go down to Rwanda's strategy to tackle NCD. Rwanda is among the few countries that, when you look at the literature review, we learn a lot from example how COVID was handled. And I think the same way should be, that's what Rwanda is doing to also handle NCDs. We have now tax-free for cars that are using natural energy. And this is really some of the activities that are happening, interventions that are happening within the ministry. And something that I would like to really share with you is the Car-Free Day. Have you heard about Car-Free Day? How many people heard about Car-Free Day here? Thank you. So the Car-Free Day is one of the strategy, prevention, that the leadership, the top leadership, has used to bring everyone together, not only to socialize, but also to reduce NCDs. Why? Because we use data. We use data for policy making. We use data to tell the leadership what is actually killing us. Now we are bearing, as we heard, the double burden of disease. We still have infectious disease, but also we are having this non-communicable disease as well. So during the Car-Free Day, what happened? We have our leaders pulling all of us, hey guys, come do some exercise so that we can reduce those burden, because we want to focus on prevention, which is free, which is available. We just need a little bit of support, coordinated efforts. So during Car-Free Day, get everyone together, do sport, but also we screen. We do screening. And during those screening, we know the numbers. We know on average how many people actually didn't know that they're having hypertension crisis. During Car-Free Day, we found actually 1% of people who came freely to do sports found that actually they were in a crisis of hypertension. We also found that BMI, especially among us women, is really increasing. We got the data from 2016, 17, and so forth. And BMI is about, BMI, we are looking at overweight and obesity, around 39%, 36%, 37% respectively, from 2016 to 2017 and 2018 as well. So my take message here is we need to change the way we are tackling NCD. NCD need to be tackled as multi-sector, as I said, but also mainstreaming budget. We talked about the budget, no single line of the budget. Mainstreaming the budget across the sectors. You can talk about agriculture on genetic modified food. We can talk about education, where we are teaching our kids on early physical education. We can talk about this Car-Free Day, which is one of the ways that we are bringing everyone to start enjoying the exercise. Also, we can talk about kids starting the exercise early. So data is important. This is the only way we can start understanding what actually the system, what actually the population is bearing. So we use data a lot, data during Car-Free Day, data that is embedded within the comprehensive approach at a community level. We do screening, and we know exactly who actually is at risk. And I think our systems should be proactive instead of being reflective. We should not wait to see, we should go and act. Rwanda is starting doing that to reverse the curve and to reduce the burden of NCDs in country, but also in the region. So I'd like to pause here, and thank you for inviting me and sharing this experience from Rwanda. Thank you.
Thank you, Janine. We need to be proactive instead of reactive, especially in the context of NCDs. And I would like to welcome Hassan Ghanen from Tunisia to also share his experience. Thank you.
Thank you. Thank you for giving me the opportunity to share with you an example to make the case for prevention. As you all know, sometimes the more we speak about prevention, the less we do about prevention. So I am going to present the results of our center that was part of a global initiative to create some centers of excellence in research that was under the auspice of National Heart, Lung, Blood Institute and United Health. And in Africa, there was 3 centers. One in Tunisia was the center that I am speaking about. And our partner from the northern country was Finland. Finland, which is known for the North Karelia project. North Karelia project is a very famous project that was successful in reducing cardiovascular disease. They were our partner in this project. Just to give you an example of, here is urbanization in Tunisia, how it moves from, around 40% to 70%, and life expectancy, how it moved from 65 to 2018. We gained almost, 25 years. Now it is plateauing there. And the transition that Tunisia passed through was quite long, but I'm not sure it will be the case for Africa. Maybe it will be very short, this transition, and we will be facing the problem of non-communicable disease very, very soon, so that the health system should be prepared for that. What is the problem of this transition, and how can the health system react to this situation? And what would be also the implication on the costing or the financing? While the epidemic could be controlled, as it was the case, look, in Finland, how when they started their program here in the 70s, they were able to reduce drastically, the mortality by cardiovascular disease. This is an example that prevention could work, and we can have some case studies documented in Africa. What would be the possible solutions? Not, continuing to focus just on the health system. We will maybe have to allocate resources to other health determinants like behavior or environment to reduce the burden. Not continuing just on the financing only the health system. It will have a limit in expanding, life expectancy. So we have to diversify this and look for other determinants of health. Also, we have to improve primary care prevention, oriented to prevention, primary care access to reduce the burden on hospitals. So in Tunisia, we started by documenting the problem. Then we sensitized the politicians and health professionals. We create partnerships. We started some demonstration project before we generalize it to the general populations. And as you see, the team here is composed of different partners at the university and outside of the university and even NGOs. This is the national, the partner. We have also international partners like the Finland here. University of Minnesota was also part of this project with us, and University Hospital of Geneva for some aspect for obesity. And we did a multi-sectorial approach. We did actions in schools, in workplaces, in primary care, and at the community. And I'm going to pass through the different actions that we have. We combined, we tried to combine, educative actions with environmental actions that are the most difficult part, of this program. So the framework is to, intervene in different settings and give the message, the chances to be heard in schools, in workplaces, in the community, in neighborhoods, and even in primary healthcare centers, along with mass media, and try to combine this with, structural change. And we proceeded through, a scientific approach with a quasi-experimental design with an intervention area and a control area. We started by assessing the risk factors, and then we intervened for 3 years, and then we assessed it at the end of the program in the intervention and in the control area. And in the middle of this program, we have the Tunisian revolution, and it was a very big challenge for us to continue the program. We thought that it would be very difficult in such circumstances, but hopefully we finished, we managed to finish the program. Here you have the region of Sousse, you have the intervention area, the control area. We sampled, in the intervention neighborhoods, school setting, and workplaces. We did the same for the intervention, for the control area, the same methodology, but we did not intervene at that stage. Data collection, we used standardized, tools to measure the main risk factors, which were smoking habits, physical inactivity, and diet. For ethical consideration, we proceeded also to a delayed intervention in the control area at the end of the program. And just to give you a few idea about what we did, we developed a guide after a review of literature, and we have a menu of actions that we can do in schools. We started by assessing the risk factors, then we intervened, then we assessed the results of this program. The interventions in school involved, not only the schools themselves, but also their family. And here you see the dietitians speaking with the mothers of the school children in interaction with the school children themselves. We did some competition between, different schools for improving physical activity. We create a group of school children leaders that took after, the actions in their schools. So we worked together with the teachers in the school. We created even, a Facebook group for them. In workplaces, we did the same thing, targeting the main 3 risk factors, screening for, blood pressure and diabetes, activities, physical activities between, factories involving women too. And we also use the paramedics who works in workplaces to improve, health education. In community, the same. We did screenings. We did also, pamphlets, go to, homes of the people. And in primary care setting, we proceeded to a training program for primary care physicians. Here you have our colleagues from Minnesota speaking about smoking, our colleagues from Finland speaking about their program, and here the dietitians also in primary care with making health education with diabetic patients. Throughout the 3 years, it was an intensive program in different settings, and we wanted to see if this is feasible to change these risk factors after I will just give you a few results because it's not, I do not have the time to give you. There is a problem, I think, with the slides. The format is not there, but when you see, red, it means that this is the control area. This is the intervention area. We were more successful in the intervention area. In workplaces, the same. We have almost 1,000 in each of the setting, and we managed to get also encouraging results for the main risk factors. Unfortunately, the format of the slides are not showing all the results for you, but as you see the green, it means good results in the intervention area. In the community, also we have screened for the 3 main risk factors, and we compared pre and post intervention. We managed to get also encouraging results for smoking, for physical activity, and for nutrition. And all this, you have these publications that you can see from this program. The challenges for this program is it was not a randomized trial. It was just a quasi-experimental design. The study duration may be 3 years for intervention were not sufficient, but we were not able to make the structural change because of the revolution. We were limited by that challenge in order to change the policy, to make, for example, physical space for path, like for walking or for cycling. This was the main challenge for us, because we know that education alone is not enough. And finish by telling that the main message here is that we have to partner to create a team and to make the structural change happen in order to make it easier for the individual, not for the society. Thank you for your attention.
Thank you, Professor Hassan. There's a long list of publications. Please seek out these publications. We need to learn from one another. We have a very brief presentation from Professor Anna Mukumbi. It's a pre-recorded presentation, so could we load it, please?
Good morning. My name is Anna Mukumbi, and I'm talking to you from Mozambique, where I am based. I work at the University Eduardo Mondlane in Maputo, and also at the National Public Health Institute in the same city. I co-chair the NCDI Poverty Network together with Dr. Jean Bookman, who is among you. I thank the organizers of this conference for inviting me to talk at the conference, and I will share through very few slides our experience and our thoughts regarding integration of pediatric community-based and primary care-based care for non-communicable diseases. I will share my slides. This is the title of my presentation. And as I said, it will be a very brief presentation with this outline. I would like to share with you the fact that there are non-communicable diseases in children and adolescents. The global burden of diseases 2019 showed that almost 1/4 of DALIs, in low middle income countries affected children and adolescents. And if taken together with injuries, this percentage is even higher. These non-communicable diseases in this group are very diverse, as you can see on the left-hand side of this slide. And these diseases are not covered by the current paradigm of non-communicable diseases prevention and control globally. This paradigm focuses on 4 main diseases and 4 modifiable risk factors that affect older people and usually reflect risks and diseases related to metabolic conditions. However, children in Africa and children that belong to communities that are poor usually are afflicted by conditions that are unique and are usually related to poverty, related to social determinants of other nature, and also related to infections and to problems in health systems capacity to deal with risk factors that are infectious in some cases, or any sort, such as congenital heart diseases that cannot get treatment. Therefore, this paradigm that was upgraded recently to be a 5x5 strategy, incorporating additionally environmental risks on one side and also diseases caused by these risks on the other, does not cover children and adolescents if we consider them as a group. To reframe non-communicable diseases and injury in these groups, but also in people suffering from the consequences of poverty, a Lancet Commission was created, and the Lancet report was launched in 2020. This Lancet report showed that these conditions, non-communicable diseases and injuries, affect much younger people in areas that are afflicted by poverty. It showed that most of the poorest billion people in the world live in sub-Saharan Africa, and